Alterations in regulation and metabolism, diabetes mellitus. Diabetes mellitus is a chronic metabolic disorder of the pancreas that affects carbohydrate, fat, and protein metabolism. It might be a consequence of a metabolic syndrome that includes abdominal obesity, hypertension, an elevated LDP, triglycerides, blood glucose levels, and a low HDL. 90 to 95% will acquire the disorder as adults. It is the 7th leading cause of death in the United States. 23.6 million people in the United States have diabetes mellitus, and that is estimated. The incidence is increased among African Americans, Latinos, Native Americans, and Asian Americans. True or false? Diabetes mellitus is a disorder of the pancreas that affects sugar metabolism. False. It's a disorder of the pancreas that affects carbohydrate, protein, and fat metabolism. So there's two main types of diabetes. We have type 1. This used to be called juvenile diabetes, and it also used to be called insulin-dependent diabetes mellitus. With type 1, we have a lack of insulin production. This usually will occur in people younger than 20 years of age. However, it can occur in people that are older than that. Type 2 used to be called non-insulin dependent diabetes mellitus. This is caused by insulin resistance. It may or may not require insulin injections. It is most common in 45 to 64-year-olds, although it is now being diagnosed in obese children. Prediabetes mellitus can lead to type 2 diabetes, heart disease, and stroke. Risk factors include being overweight, especially that intra-abdominal obesity, and obesity. Diagnosis is made by one or more abnormal blood tests. We may see a hemoglobin A1C of 5.7% to 6.4%, or a fasting blood glucose of 100 to 125 milligrams per deciliter, or an oral glucose tolerance test of 140 to 199 milligrams per deciliter. Prediabetes can be delayed or avoided with weight loss and increased physical activity. Hyperglycemia is an elevated blood glucose level. It may be associated with pancreatitis, excessive adrenocortical hormone secretion or administration, or some medications or treatments. It may require the use of insulin, but it does not indicate that there is diabetes mellitus. So basically, the function of insulin includes carrying glucose into the body cells. So if we don't have insulin, glucose, which is our major source of energy, does not get to the cells. It also promotes the liver storage of glucose in the form of glycogen and inhibits the breakdown of glycogen into glucose. With type 1 diabetes mellitus, the islet cells in the pancreas once again no longer produce insulin. This causes elevated blood glucose. It can't get into the body cells, so it stays in the bloodstream. It also causes the body to begin to break down fat and protein into energy because it's not getting that glucose into the body's cells. Lipolysis is the term we use to refer to the breakdown of fats, and it produces ketones. If we have an accumulation of ketones, it can lead to metabolic acidosis or a condition called ketoacidosis. The body will attempt to self-correct ketoacidosis with deep, fast, heavy, labored breathing called Kussmaul's respirations. That's where we attempt to blow off extra acid, which is found in carbon dioxide. Ketones have a fruity odor on the breath. Complications include circulatory collapse, renal shutdown, and death. It is considered to be an autoimmune disorder, but it has been known to be caused by a virus. Studies and trials are being conducted that may improve treatment of or cure diabetes. Type 2 diabetes is considered to be an inherited disease. Risk factors include that intra-abdominal obesity and a sedentary lifestyle. It also includes gestational diabetes, age, being over the age of 40, are a couple of the other ones. Insulin is produced in the type 2 diabetic, but the body is no longer able to use it effectively, or it just does not produce enough insulin. The high serum glucose will pull fluid into the vascular system. This causes polyuria. Because so much urine is lost, the client will experience thirst or polydipsia, and that's caused by an increased osmolarity of the blood. In other words, we have a concentration of products in the bloodstream, and that causes us to be very thirsty. That's honestly one of the first signs of diabetes is polydipsia. Due to the body not using glucose as the fuel source, the client is hungry and experiences what we call polyphagia, the 3 P's: polydipsia, polyuria, and polyphagia. True or false? Type 2 diabetes occurs as a result of a lack of insulin production. And we know that's false. That's type 1 diabetes. The 3 classic symptoms, once again, of diabetes are those 3 P's. We have polyuria, polydipsia, and polyphagia. In addition, we may see weight loss, weakness, thirst, fatigue, blurred vision, and dehydration. These clients have an increased risk of infection because glucose supports bacterial growth. There's an abrupt onset with type 1 diabetes and a gradual onset with type 2. Gerontological considerations include an increased risk of dementia, an increased side effect of hypoglycemia in relation to diabetic medications. These clients will have glucose or ketones in their urine or both. We can do blood sugar tests such as random, fasting, postprandial, which is 2 hours after a high-carb meal, oral glucose tolerance test, the glycosylated hemoglobin or hemoglobin A1C, which reveals glucose levels for the past approximately 120 days. Treatment will depend on the type of diabetes. First of all, we need a tight blood glucose control because that's going to help prevent complications. And that needs to start from day one because those complications are probably going to appear at some point, but we can delay that start or minimize the complication with tight blood glucose control. Diet and weight loss are major components of treatment. Diet may be enough to control diabetes type 2, and the diet will be dependent on gender, age, height and weight, activity, occupation, health status, culture, and dietary habits. The diet should include 3 meals and 3 snacks to keep the energy levels consistent. We want to keep food in the stomach during our awakening hours. Um, so we want to not allow the stomach to get too empty. It also is going to help never mind. Exercise. Exercise can reduce the need for insulin as exercise helps the muscles take glucose in without the benefit of insulin. It also improves blood coagulation, but it does increase the risk of hypoglycemia. So diabetics that engage in heavy exercise should monitor glucose levels very carefully. So let's talk about insulins. All clients with type 1 diabetes have to use insulin. It's important for nurses to be familiar with the types of insulin, their onset, peak, and duration. Insulin will be administered with injections with needles, pins, jet injectors, and pumps. We need to alterate the areas of injection to avoid lipoatrophy, which is a breakdown of subcutaneous tissue, or lipohypertrophy, which is a buildup of subcutaneous tissue. Alternatives to injections are being developed, but we don't have them yet. So again, all type 1 diabetics will require insulin, and some type 2 diabetics require insulin. And some people who have an increased insulin level because of treatment, such as total parenteral nutrition, or maybe they're receiving corticosteroids for a procedure for a certain period of time. It is contraindicated in hypoglycemia, which makes sense, and adverse effects include hypoglycemia that can result in brain damage, shock, and possible death, weight gain, lipodystrophy, and allergic reactions. So different types of insulin include our rapid acting, which would be like our Lispro, also known as Humalog, Novolog, or Apidra. Its onset of action is 15 minutes. It does have a shorter duration of action, 3 to 5 hours. Its peak action is 1 to 2 hours. In other words, it will be working its best in 1 to 2 hours. It is the most like our endogenous insulin. Endogenous means what we produce ourselves. Exogenous is the insulin that we would administer. It's coming from outside the body. It should be administered before or during a meal. Then we have short-acting insulin. This would be our regular insulin, such as Humulin R or Novolin R. It can be given as an IV bolus, an IV infusion, intramuscularly, or subcutaneously. It is the only insulin that would be administered IV. Its onset of action is 30 to 60 minutes with a duration of 6 to 10 hours and a peak action of 2 to 5 hours. Intermediate acting would be our NPH. This insulin has a cloudy appearance, and if you're mixing insulins, usually you would mix an intermediate with a regular insulin. Always draw the clear before the cloudy because you don't want to make the clear cloudy. Make sure that you roll it gently between your hands to mix it prior to drawing up the medication. Its onset of action is 1 to 2 hours. Its duration of action is 10 to 18 hours, with a peak of 4 to 8 hours. Your long-acting insulin would be like your Glargine or Lantus, or your Detamir or your Levemir. Its onset of action is 1 to 2 hours with a duration of 24 hours, but it does not have a peak action. And then we also have combination insulin, such as 70-30 or 50-50, which is a mixture of intermediate and rapid-acting insulins. We can do a basal bolus or sliding scale insulin dosing. Clients that receive rapid-acting insulin with dosages are going to be dependent on blood glucose results. With the basal bolus, this is the preferred method. We give the long-acting daily, and then when we test the blood sugar, we'll give the rapid-acting for blood glucose levels that are of a certain level. Nursing interventions include testing the blood glucose prior to administration, making sure the client eats after insulin injections, especially with that rapid-acting and short-acting insulin, and making sure that it is administered subcutaneously. So let's look at some oral anti-diabetic agents. These are going to be used only with some of the type 2 diabetics. This is going to include your biguanides, contraindicated with renal disease or dysfunction because it can accumulate in the system, alcoholism, metabolic acidosis, and hepatic disease and heart failure. Adverse effects include abdominal bloating, nausea, cramping, diarrhea, hypoglycemia, and lactic acidosis. An example would be metformin. Then we have our sulfonylurias. This is going to once again be for type 2 diabetes. It can be used with metformin. It is contraindicated if we're administering insulin, and of course contraindicated with hypoglycemia, alcohol use, advanced age, or an allergy to sulfa, because this is a sulfa product. Adverse effects definitely include hypoglycemia, hepatic or renal disease, weight gain, skin rash, nausea, and heartburn. Examples include glipizide or glyburide. Then we have our glinides. Again, type 2 diabetics. It is contraindicated again with insulin or alcohol, advanced age, or allergy to sulfa. Adverse effects include weight gain, and examples would be your repaglinide. Then we have our thiazolidina. Yeah, I'll let you look at that one in your medication sheet. Not sure quite how to pronounce that. Again, it can be used with your biguanides or your sulfonylureas. Contraindicated with heart failure, liver, or renal disease. Adverse effects. It can exacerbate heart failure. We may see peripheral edema, weight gain, reduced bone mineral density. Your alpha glucosidase inhibitors usually are used in conjunction with other oral hypoglycemics. Contraindicated with inflammatory bowel disease, malabsorption syndrome, or intestinal obstruction. Adverse effects include flatulence, diarrhea, abdominal pain, elevation of liver enzymes in higher doses. Your dipeptidyl Peptidase IV inhibitors are adjuncts to diet and exercise to help improve glucose control. Adverse effects would be upper respiratory tract infections, headaches, diarrhea, and hypoglycemia, especially if it's used in conjunction with other oral antidiabetics, and pancreatitis. Bariatric surgery might be an option for weight loss with some type 2 diabetics. The pancreas or islet cell transplant is another option that may allow for insulin independence. This is a process that's only available for type 1 diabetics, but islet cell transplants are only effective for about 2 years. Gerontological considerations include a decreased taste that may lead to hyperglycemia. Decreased vision can lead to inaccurate insulin dosages. Nurses, we need to teach or reinforce diabetes care, including disease process, their diet, exercise, medication regimen, and administration, monitoring of glucose, inspecting their feet routinely, routine appointments with the provider, and eye examinations. A complication with diabetes is neuropathy. This is going to be one of our macrovascular disorders. Microvascular would be like in our eyes and kidneys, those small little capillaries. We have problems there. Macrovascular are going to be larger and will involve our cardiac and the neuropathies. With diabetic neuropathy, they may have an altered sensation in their lower extremities to the point where they no longer have feeling in their lower extremities, especially. They can develop sores on their feet and not even be aware of it. They can step on things and not be aware of it. So they should always be encouraged to wear shoes, even in the house. Never go barefoot. And they should be taught how to use a mirror to examine their feet on a daily basis. Diabetic foot ulcers, or DFUs, are very difficult to heal because they have a decreased blood flow and the client doesn't know they're there. So they can become pretty significant before the client even finds it. They're usually round in shape. They're usually very dry. They can become infected very easily, and that infection can go to the bone, leading to osteomyelitis and potential amputation. Diabetic ketoacidosis, or DKA, is a type of metabolic acidosis caused by an accumulation of ketones because of insulin deficiency or an inability to use insulin that has been administered or is circulating within the body. It's often seen with hard to control diabetes or non-compliance with treatment or in cases of infection. These clients may have undiagnosed diabetes when they're admitted with DKA. This is the first time they've ever heard that they've had diabetes. These clients experience weakness, thirst, anorexia, vomiting, drowsiness, abdominal pain, Kussmaul's respirations, low blood pressure with a weak, rapid pulse. So we diagnose by looking, and we see an elevated blood glucose. We have urine that has glucose and ketones, and we look at their blood pH, which they're going to be acidic. Treatment will depend on the severity of the DKA, and the main goals will be to reduce the elevated blood glucose, correct the fluid and electrolyte imbalances, and clear the urine and blood of ketones. We're going to administer IV insulin, and remember, regular is the only insulin that can be administered IV, so that would require frequent blood sugar checks, and then we titrate the IV glucose to make sure that they are, or the IV insulin, to make sure they're receiving the proper amount. And we may also have to give glucose until we get their electrolytes in balance. They will receive high doses of isotonic fluids and potassium replacements. Very important to monitor vital signs, the blood glucose, heart rhythms, and urine output. Because remember, we have alterations in our potassium levels. True or false? Diabetic ketoacidosis results from a client being a brittle diabetic or noncompliance with diabetes treatment. True. Hyperosmolar hyperglycemic nonketotic syndrome, or HHNS, is hyperglycemia without ketones. This results from serious illness, diureses, blood glucose over 500, a normal pH level, excuse me, and it's more common in undiagnosed or type 2 diabetes. We have hypotension, mental changes, extreme thirst, excuse me, dehydration, tachycardia, fever, and neurological symptoms. These clients have elevated blood glucose and serum osmolarity. We diagnose it by looking at their blood glucose levels and their serum osmolarity. We see decreased serum potassium and sodium. We treat it by administering insulin, correcting their fluid and electrolyte imbalances, and monitoring blood glucose, neurological, cognitive, and their fluid and electrolyte status. Hypoglycemia is a low blood glucose level. It can be an adverse reaction of diabetic medications. It can also be an adverse reaction of not eating or taking diabetic medications, not eating sufficient calories with diabetic medications, or exercising more than usual, or alcohol. These clients experience nausea, drowsiness, hunger, malaise, excessive perspiration, confusion, coordination difficulty, personality or behavior changes that can actually give the appearance of being drunk. So we look at their blood glucose levels and do that glucometer test. Medically, we want to administer 15 to 20 grams of a simple carbohydrate as soon as possible. And we always want to do this orally if the client is alert enough and able to eat or drink. If they are not, then we can administer a medication called glucagon, which is a natural hormone that's secreted by the pancreas, and we give it for severe hypoglycemia subcutaneously, especially, once again, in clients that do not have IV access. Adverse effect is vomiting, so always make sure that you turn them on their side as soon as you administer it or prior to the injection. We can also administer 50% glucose intravenously. We can also give complex carbohydrates As soon as that hypoglycemia has been corrected by glucagon or IV dextrose to help keep their blood glucose levels up. Glucagon and IV solutions are going to rapidly raise their level, as are things like orange juice or a candy. It's going to get their glucose level up quickly, but it's not going to keep their glucose level up. So we need to administer something such as a fat or a protein to help keep that glucose level up. That complex carb. Uh, these would be things like cheese and crackers, or peanut butter and crackers, or a small peanut butter sandwich, etc. Nurses need to monitor the blood glucose levels, encourage the client to eat within 15 minutes of insulin administration, and encourage those regular meals and snacks. Most important thing, once again, remember that hypoglycemia is not necessarily a complication of diabetes medications. It can be a disease process in and of itself. Again, peripheral neuropathy. This is a pathologic change in those nerves. We see this happen with poor glucose control, decreased blood circulation to the nerve tissue. We may have motor neuropathy, a weakened and or atrophied muscles, sensory neuropathy where they have those paresthesias, up to a total loss of feeling, and autonomic neuropathy, which affects nerves and organs. These clients can have pain, swollen feet, disturbing sensations, digestive, urinary, and sexual dysfunction, dizziness, and smaller skeletal muscles. Neurological examinations, screening tests, and electromyography can be used to diagnose neuropathy. Diet and exercise are done to help control blood glucose. Pain relief measures, drug therapy, antibiotic therapy, and drugs to help reverse diabetic neuropathies can be administered. Nurses need to educate clients about the prevention of neuropathies and adherence to the medical regimen and proper foot care. Gerontological considerations. Good foot care is important in the older adult due to other comorbidities. And if a person has diabetes, we do encourage a podiatrist consult to help make sure that feet are being maintained, and we want someone that has been trained in doing nail care, taking care of these clients. This picture shows a monofilament, which is how we determine if they're able to feel, and the lower picture shows a DFU, the diabetic foot ulcer. You can see it's very round. It's also very dry and just has that very specific look to it. Diabetic nephropathy is the progressive decrease in renal function. So we see glomerular deterioration, usually seen with retinopathy and vascular changes. Again, this is going to be your microvascular changes. We also see it with poor glucose control and high blood pressure. They help contribute to the development and progression. These clients may have swollen feet and hands. They have a gradually increasing blood pressure, tiredness, and weakness. We diagnose by looking at serum creatinine tests, renal creatinine clearance tests, albumin in the urine, and treat it by controlling their blood glucose levels and their hypertension, drug therapy, dietary protein reduction, and smoking cessation. We monitor blood sugars and blood pressures, provide client education on the rationales for medical regimen, and encourage routine follow-up appointments, especially with a nephrologist once things progress. Diabetic retinopathy is the pathologic changes in the retina because of diabetes. These vascular changes are due to poorly controlled blood sugar. Types include a non-proliferative, which is milder, and proliferative, which can lead to blindness. These clients have a diminished visual acuity. We encourage ophthalmic examinations frequently, usually at least yearly and sometimes even biannually. We can also diagnose with a fluorescein angiography. Treat it with routine eye examinations, may require laser photocoagulation, vitrectomy, and ACE inhibitors. Nurses encourage therapeutic regimen for tight glucose control, and we provide client education on complications of diabetes. Encourage those regular ophthalmic exams and medication regimen. And then vascular disturbances. All arteries and arterioles are going to be more susceptible to atherosclerotic and arteriosclerotic changes. This involves thickening of those arterial walls and an increase of coronary artery disease and hyperlipidemia. These clients may have pale, cool extremities, leg cramps, gangrene, skin ulcers, and myocardial infarctions. We diagnose by looking at elevated triglyceride levels, angiography, and Doppler ultrasonic flow studies. We treat it by lowering lipids, using vasodilators, platelet aggregation reduction drugs, may require amputation, insulin, and anti-diabetic drugs. Nurses encourage smoking cessation, client education on diet, exercise, follow that medical regimen, and monitor blood glucose levels.